I'm Dr. Adeso. I did my residency at MCV, just down the road, and then I did a fellowship in minimal invasive surgery, so basically small incisions at UVA. And then I started working for HCA since 2008. So basically I've been a practicing minimal invasive general surgeon for HCA since 2008. The accent is from Cameroon. I'm originally from Cameroon. I came here after high school about 25 years ago. So we're here today to talk about hernias. And I'm hoping by the time you leave, we'll know what a hernia is, how and why it happens, what options we have, and what to expect when you have surgery. Hernias are really common. It's more than 1 million actually, but we do more than 1 million hernias in the United States every year. And it's anticipated that 1 out of 4 men have an inguinal hernia. So hernias are pretty common. As a general surgery, you see a lot of hernias. What is a hernia? Most people I see in the office, you come in, you have a bulge. And you always hear, well, are you going to take the hernia out? But in reality, a hernia is actually a defect. It's actually a hole, for lack of a better word. If you think of the abdominal cavity as having different layers, we all see the skin. But what's holding everything inside is a very thick layer. And if for whatever reason you have a hole there, then your insides come through it. And then you see this bulge. But the actual issue is not the bulge. The actual issue is the defect in the abdominal wall. Is that defect, is that hole. So that's what a hernia actually is. It doesn't matter where it is. It could be in the middle, it could be in the groins, it could be in the sides. But once you have a defect, something can go through, especially bowel. Because inside your bowels move freely. It's meant to move freely. So imagine a container and you have a hole in it and it's full of water or stuff that moves freely. It will go right through it, and then you see this bulge sticking out. What causes a hernia? Well, a hernia is basically, as I said before, it's a weakness in the abdominal wall. There are some areas that are naturally weak. The belly button is one of them because of our umbilical cord. So a lot of people have hernias in the belly button area because that's a very thin layer. And over years of activity, of stress, of playing, it gets weaker and weaker. The hole gets bigger and bigger, and then the bulge happens. In men, you have the groin, left and right. Reason being, our testicles travel through the groin down into the scrotum. So it's a natural weak spot. It can happen in women too, but definitely more in men. It's a natural weak spot. After years of activity, it gets weaker and weaker. You end up with a hole, and then you see that bulge. And it's not uncommon to have people complain that the discomfort shoots down to the scrotum or the testicle, because that's the same tract that you have your nerves, you have the blood supply that go down to the testicle. It goes through that same tract. It can also happen because of other things. Surgery is a big one. Whenever we do surgery in the belly, you cut through all these layers to go in. When you're done, you stitch it up. But you've violated that area now. You have little holes from the stitches. So it always starts small, but as you're doing activity, it starts getting bigger and bigger again. So whenever you've had surgery, there's always that risk that you can have a hernia where the surgery was, especially when it's in a spot that's not a natural weak spot. And then you can have things like trauma. But the big three are the weak spots, the belly button and the groin, and then you have surgery. Frequent heavy lifting. I mean, we're all active. If you've had abdominal surgery, coughing, that goes together with smoking. People who smoke cough a lot. And so each time you cough, there's abdominal pressure. And each time there's that pressure, you're pushing against the abdominal wall. And it gets looser and looser. Being overweight is another risk factor. There is a lot of pressure in the abdominal cavity when you're overweight, especially when it's central obesity or central overweight. Because each time you cough, the pressure is way more than someone who is skinny. So your abdominal wall has to contain that. And after years, it gets weaker and weaker. Pregnancy kind of goes in the same light because the abdomen is bigger, it stretches. Imagine having a small belly button hole or hernia, and as you get pregnant, it stretches, and then when you give birth, now you have a big hole. It doesn't go back in. The belly goes back in, but the defect is still there. The different types of hernia, okay? The first one is if it's reducible. What does that mean? You see the bulge, and you can push it in. Most people say they notice it after standing for a while or being active. It sticks out. But once they're asleep or they wake up in the morning, you don't see it anymore because gravity has pulled everything in. The hernia is still there, the hole is still there, but it's reducible because what's inside goes back in. When you push it, it goes in. That's the good kind because it goes in and out. What you don't want are those that don't go in, the non-reducible ones. They come out, and for whatever reason, it's tight, it's stuck. It's gone through this hole, and now it's stuck. So it sits there. When you lie down, it's still there. When you push it in, it doesn't go in. Usually, they start causing a lot of pain and discomfort. Now, when you cannot push a hernia in, you have different subtypes. We call it incarcerated. You hear that word a lot. They say my hernia is incarcerated. It's like being in jail, honestly. That's how I look at it. But it's gone through, and it's stuck. It can't go back in. So it's incarcerated. If you see a little picture like that, that's the defect. That's your bowels. That's our bowels inside. They're moving freely. Now it's gone through the hole, and let's say it can't go in anymore. It's incarcerated. When that happens, you can have an obstruction, right? Think of your bowel going through a defect, and now it's tight. Stuff can't move through anymore. You start feeling nausea. You get more pain. You even vomit because stuff can't go through the bowel anymore because it's now stuck in that hernia, in that hole. And the worst kind is when it gets strangulated. It's so tight, it cuts off the blood supply. What happens is it goes through, it starts swelling. You cannot ignore it. It swells some more. And then by the time you realize it hurts so much because it's choking it off. And we use the word strangulated because all of a sudden, the blood supply, the blood supply doesn't go through anymore. And if you don't end up in the operating room, pretty quickly you end up with dead bowel or whatever is going through dies off because of no blood supply. So you don't want a hernia to get, this is an emergency basically. If you have someone coming to the emergency room, and we see that from time to time, a hernia that's very tender, red looking, you can't even barely touch it, and you can't push it in, you have to go to surgery because you got to free it up so you can push it back in. Same thing again to describe what I just said. You have an incarcerated hernia. It goes through, can't come back out. If it stays that way, it can become strangulated. The blood supply basically chokes off, and you end up in an emergency. Otherwise, the part that's sticking through can basically die off. And all of this, again, because you have a hole. All you see is this bulge. All you know is you have a tender bulge. But the problem is the hole. You see, what's sticking through it has to go back in. So where can you have hernias? I said earlier, basically anywhere in the abdominal cavity you can have a hernia. It can be up between the belly button and your chest. We call that an epigastric hernia. It can be in the groins. It can be in the belly button. It can be from a surgical incision wherever you were cut. And then you have other less frequent ones along the flanks and things like that. But anywhere in the abdominal cavity, especially if you had surgery before, you can have a hernia because you can have a hole. That's just a close-up picture. Higher up in the epigastric area, belly button, in the groins. You have different kinds in the groins, but basically you show up with a bulge in your groin. It gets all complicated, but basically you show up with a bulge in your groin. And it can be along the sides. They call them Spigelian hernias. But they're all defects in the abdominal wall. So signs and symptoms, how do people show up? Again, most people show up with a bulge or a lump. Sometimes it disappears when they lie down, and then it comes back. If you're unlucky, it stays out the whole time. It means it's stuck. It's already incarcerated. It can't go back in. It gets bigger with time. When you strain, you got to think pressure. Whatever causes intra-abdominal pressure will push your bowels through the hernia. Coughing, sneezing, laughing, sit-ups, playing, straining when you have constipation. Whatever makes you bear down and increases your core pressure, it'll squeeze it in the inside and your bowels will stick out through any hole that you have. Some people complain not really of pain, but they feel the heaviness of the hernia bulge. And if you start getting an obstruction, you can get nausea and vomiting because the bowel has gone through again, and now you're vomiting because nothing can go through. How do we diagnose hernias? Really, 90% of the hernias are basically by physical exam. You come into the office, most people already know they have a hernia. You can see the bulge, you push on it, you can feel the weakness as you push on the belly, as you push on the abdominal wall. So a lot of it is just by exam. You see the bulge in the groin, you see the bulge where surgery used to be, you see a surgical scar, and sure enough there's a bulge, you know it's from the surgery. Rarely you have to do more scans, like a CT scan or an MRI, because sometimes it gets complicated. You can't tell if it's a bulge from a hernia or a bulge from a mass. Then you can do a CT scan or an ultrasound. But most of it is just by physical exam. You come to the office and you can diagnose it. Once in a while, yes, we send you to get usually a CT scan or an ultrasound, but usually a CT scan. So what options do you have if you have a hernia? One, you can watch and wait. It is not a good option because reports have shown that people who try to watch and wait eventually end up having the hernia repaired. And now you're repairing it when it's much bigger as opposed to when it was smaller. All these hernias begin small. The hole is always small to begin with. It doesn't double in size overnight. But over months, sometimes even years, it gets wider and wider. So whenever you wait, most people, 80% usually, will end up requiring surgery down the line because it starts causing pain. So it's never really a good option. The only reason to really watch and wait is if you're a poor surgical candidate. If for some reason it's too risky to have surgery, cardiac-wise, lung-wise, then yes, it makes sense to watch and wait if the hernia is not bothering you, because the risk of surgery now outweighs the risk of repairing the hernia. People have tried belts. It helps some. It may make it a little bit more comfortable, but honestly, it doesn't do anything to reduce the hernia. You're better off putting your finger or your palm right over it, because you can really put pinpoint pressure, or in the groin when you're coughing, because it's tough to really have an appliance that puts pinpoint pressure where you want it when you want it. So people try it, and I think there is some relief, but it really doesn't do much long term. Basically, the last result is surgery. You end up with surgery. Nothing you can take will make it smaller. You can't take a medication to make it smaller. It'll either stay the same size or most likely get bigger over time. So the only way to fix that hole, because it's an actual physical hole, is to surgically close it up. A hernia surgery is basically closing that hole, whatever technique we use, and there are different techniques. But at the end of the day, you're trying to patch a hole. That's what you're trying to do with hernia surgery. Let's just talk real quickly about the different kinds of hernias. So you have the groin hernia, which is very common in men. Sometimes they're indirect or direct, but basically you have a bulge in the groin, especially when you stand. Because when you stand, gravity, your bowels fall down. At the end of the day, you feel the bulge that you didn't feel in the morning. That's usually how it starts. And then there's usually some discomfort in the groin because it's been hanging there like that for hours. Sometimes it's a little lower, we call it a femoral, but bottom line is you have a hernia down in the groin. You see a bulge down in the groin. Men more than women. It's usually more common on the right side than the left. This is just a little interesting fact, because the right testicle descends later than the left testicle. So for that reason, the right side is usually weaker. So in men, you see it more on the right than left, but it can happen on both sides. Usually premature babies have it because the abdominal wall is not yet well developed, so they have a hole there. How do people present? Swelling in the groin. As you increase your intra-abdominal pressure, as you cough, it gets bigger. It starts causing pain. Smoking is a big risk factor because you're coughing when you smoke, and smoking isn't good for healing, especially when you've had surgery. Your tissues don't heal well. How do you treat it? Again, surgery is the only way to treat a hernia. Usually, it's about an hour surgery, sometimes a little bit more. There are different ways of repairing it. But again, remember, at the end of the day, you're closing a hole in the groin for groin hernias. You can do the open technique, which has been around for more than a century. You make an incision in the groin and you fix it that way from inside out. Or you can go the minimal invasive, which is what 90% of us do now. You make small incisions and you repair it. And we'll talk about mesh, because I hear a lot about mesh. So this is just a picture of how you repair the groin hernia. This is groin hernias. Again, if you want to do the open surgery, small incision in the groin, over the right side or the left side. You're repairing it from outside in, right? You go in through the layers, you push everything in, you close the hole, and you lay some mesh for reinforcement. If you want to do it with a small, which is what we do now for the most part, is the minimal invasive, is 3 small incisions away from where the hernia is. Because remember, when you're doing minimal invasive, you're coming in with small incisions. So the incisions are made away above the belly button, 1, 2, 3. You go inside. The person is asleep, they're lying on their back. You put a camera in, the middle one is the camera. You take a look and you see a hole. That's the hole looking from the inside, on the right side. Everything is down, the bowels are down here. You've insufflated the belly, you're relaxed so you can insufflate, so you have working space. See, all of this is working space that normally you don't have when you're awake. But after you insufflate, you have all this working space. You're not in the intestines. You're inside the abdominal wall. You're in the abdominal cavity, but not in the intestines. You have that space now, and that's the hernia. If you look from the outside, you see the bulge. But looking from the inside, that's the hole. We free up all this tissue here, and you lay mesh. The whole idea is to patch that hole. So you've closed it by laying the mesh basically like that. It's a big piece of mesh. If you put a small piece of mesh, it may move one way or the other and your hernia is back. So you don't do a little mesh. We do a good size 10 by 15 mesh, like the size of my palm, and you block that entire area. But you bury the mesh inside the abdominal wall so the bowels don't see it. You bury the mesh inside, and then you sew it back up. But now you formed a new wall patching that hole. So when you stand, nothing goes through. The mesh grows into your tissue and becomes one. And so you have a nice layer there patching the hole. That's how we do it. This picture is with the robot, which we do for the most part, because you have it's finer dissection. And this is just a picture of the robot. The small instruments, 3, goes in, and then you control it. We use the word robot, but you control everything in it. You control the movement of it. You control these arms, you control the scissor, you control everything you're doing. It doesn't do anything on its own. But it's good over the open because it's less pain. It's 3 small incisions, and you don't have that swelling in the groin that you do when you have an open incision. I would say about 90%, maybe more, 95% we do now with the robot. A very large hernia, sometimes, yes, you have to make an open incision because it's just so large that you can't do it with the small incisions. But it's rare to find that. Very rare. So groin hernia surgery is basically outpatient surgery. You come in, surgery is about 1 hour, 1 hour, 30 minutes maybe. After surgery, I send you home with some pain medication and stool softeners. You can be out of bed walking, and yes, you can climb steps even on day 1. That's all light activity. Obviously, you're going to be slow, and you can shower the next day. But out of bed and walking is good. It will be uncomfortable for a while, but it gets better as you walk. No baths, because you don't want to soak the wounds for about 2 weeks. You can shower, and then you pat it dry. But you don't want to sit in a bathtub, for example, or go swimming, because you want the wound to heal first before you soak it like that. Light activity, again, is good. Walking, just leisurely walking. Climbing steps is okay. You can drive, but it usually takes about 3 days when you're off pain meds to be able to drive. You don't have to wait 4 weeks to drive. As far as heavy activity, you want to give it 4 to 6 weeks because you want that mesh to settle well before you start doing heavy stuff. It takes a while to settle in and grow in between your tissues. So we normally say 4 to 6 weeks of no heavy lifting, around 15 pounds. But the bottom line is you don't want any straining. You're trying to avoid straining. Whatever you're doing, you're trying to avoid straining. So I consider heavy activity as anything that makes you to strain. Sit-ups, lifting something heavy, some kind of heavy sports, running, you can't do any of that. You take a stool softener so you don't get very constipated. That happens too sometimes. And you don't want to wait to get constipated before you take the stool softener, because then it's too late. You want to take the stool softener after surgery or even before surgery, maybe a day or two, just to get it going. If after a week you don't need it, then you stop it. What are some of the complications? This is just talking about the groin hernias now. Hernias can come back. If you don't repair it well, it'll come back. So you want a good solid repair. Now, if it takes 40 years to come back, then that's okay, but the hernia shouldn't come back after 2 or 3 weeks. It means that somewhere it wasn't repaired correctly. Nerve pain. This you really see only with the open approach. There's a very delicate nerve in the groin. And if that nerve gets irritated, it can really be a drag. People who've had nerve pain in the past, because it's a shooting, stabbing pain, and you just don't know what to do for it, quite frankly. You don't see it luckily when you do the minimal invasive, when you do the robot or the laparoscopic, because you're going too deep and the nerve is out of the way. But you used to see this more when we did open hernia surgeries, because you see the nerve, and then if you start irritating the nerve, you can have that kind of nerve pain. It's one of the things everybody dreads having. Luckily, it's very rare. These other two are basically injuries to blood supply that travel through that groin into the testicles. It shouldn't happen. It rarely happens, to be honest, that you have to injure it. Most of the time, you can free the tissue and lay the mesh there. Luckily, I've never had that happen, but it's one of those things that if you have, is really either the hernia was so big or you just need more experience. Infection is almost never. That's where the mesh talk comes into play. And the groin, 98% of the hernias we use mesh in the United States, not just here. And the groin has been really good as far as mesh with infection. It just never gets infected, especially when you're doing it with the laparoscope or with the small incisions. You wrap that mesh up, you push it in the belly, and that's it. No chance for infection. It's deep inside, no chance for infection. Even if for some reason you have a wound infection, it doesn't get all the way down to the mesh because it's down deep. One of the advantages of doing it with the small incisions as opposed to a big open incision. You can never get to the mesh. It's deep down inside. Bleeding and bruising, again, highly unlikely. And then there's groin swelling when you do the open technique, but the swelling does go away. All in all, the complications are very rare. The biggest issue people have is pain after the surgery. It's really pain. The pain gets better each week. I tell everyone you're going to start with a certain level of pain. We're all different. Bottom line is each week the pain should get better and not worse. If your pain is 10 out of 10 on day 1, by day 4 it should be some number lower. If it's 6 out of 10 on day 1, by day 4 it should be a number lower. If the pain is getting worse, then something is wrong. But most people, if the pain is getting better, you're like, okay, yeah, I can see it's getting better. Maybe the first week was a little rough. By the second week, you're doing more. By the third week, you feel it now and then. By the fourth week, you can still feel something, but it's not bad. That's the usual trend. So the pain should not be getting worse, it should be getting better. So you'll need pain medicine maybe the first couple of days. You need less when you do it with the robot or the laparoscope because it's small incisions. But for both, you need pain medication. But again, it should be getting better as the days as days go on. As you move each day, you realize it's looser and looser. The rest of the complications are pretty rare. Umbilical hernias, for some reason they're more in women. I don't know why, but men have it also. Again, overweight plays a role because, again, as your belly gets bigger, there's a lot of pressure, and the little spot in the belly button just gets weaker. And pregnancy is one of those risk factors also. So that's basically the belly button bulge. You come in with the bulge, but the problem is the defect, the hole on the inside. And what's happening is part of your insides are sticking through it. So you see the bulge. And that's why you should be able to push it in and it goes in. But it comes right back out because the hole is still there till you patch the hole. Again, Surgery is the only way to take care of it. Permanent solution. It's also about an hour surgery. You can also do it open with a small incision, or you can do with a robot with 3 small incisions. Now, if you have a belly button hernia that is very small, I make a small incision around the navel and I fix it that way because it's a small incision. It's a small hole, even though it's bothering you. Small incision, and if the hole is so small that you don't need mesh, then I just stitch it closed. Because I hate to make a small wound bigger or a small hole bigger just to lay mesh underneath. All right? A lot of people come with a very small defect. It's causing pain and they don't like it. So yes, I make a small incision because it's small, lift the skin up, push everything back in, and stitch it closed. No need to put mesh underneath if you don't have to because the hole is small. Now if it's a big size hole, then yes, I put a small mesh, if I can, underneath, and then I close. The mesh doesn't go on top because it just blows it off. You want it underneath. Put the mesh underneath and then I close the hole. But a lot of patients I've had in the past, their hole is so small I just basically stitch it closed. So it all depends the size of the defect. It really does. So if you have a big enough hole where you're going to end up with a big incision, then I prefer to use the small incisions because I don't want to have a big cut. When you can have 3 small incisions on the flank to repair any size hole that you have. So this is just an example of a hernia that's there. There's the bulge. You go in with 3 small incisions on the flank, away from where the hernia because you want to come in with a camera. The person is asleep. You insufflate to create working space. Again, bowels are down. Whatever was in that hole, the robot is you're reducing it back into the abdominal cavity. You want it back in. So you're left with just the hole. See, this stuff was stuck in there. So the person had a bulge that was always there. You push it back in, and now that's your hole. You stitch it closed from the inside. And that's where the robot is really nice because you can stitch from the inside. This is all inside. Now if you just leave it like that, you see the spaces in between. That's where hernias happen again. There's a weak spot there, there's a weak spot there. No matter how tight you make it, you can have a risk of having a hernia again because you have little holes. Hence we lay the mesh for reinforcement. So that's that extra reinforcement so the hernia doesn't come back. And at the end, no matter how wide or big this hole, this defect was, you end up with just 3 small incisions. You feel the pain here for sure. These don't hurt that much, but it makes sense because that's where the work was done. Again, it's outpatient surgery. Unless you have a very big hernia, then you stay. You must not go home, but most people go home because it's small. Same plan like the groin. Pain medication, stool softener, out of bed walking the same day. It's good for you. You can shower because the incisions are small. No baths. Light activity again. Drive when you're no longer, you can drive when you no longer require pain medicine. But no heavy lifting, no strenuous activity for 4 to 6 weeks. You want those stitches to seal. You want the tissue to seal. You want the mesh to incorporate before you start doing heavy activity. Complications, hernia can come back. That's why you need to do a good repair. And that's why we use mesh. That's a big thing. That's the issue with mesh. That's why we actually use mesh because it definitely reduces recurrence. If not, we will not use it. But it definitely reduces recurrence. If you just stitch that hole, yes, it might hold. But it's usually tight. There's some tension. And sure enough, the stitches will give. And in 1 year or so, you have a bulge again. And that's the importance of mesh. That reinforcement definitely helps. That extra layer definitely helps. You got to be careful not to injure the bowel. Infection, again, is very rare because you roll that mesh up, you put it through that small hole, and it's inside. No risk of infection. Obviously, if you start injuring bowel, then the risk of infection is higher, so you don't want to do that. Mesh erosion, it used to happen when the meshes were old school, like heavy-duty mesh. When they started making a little bit of history on mesh, when they started doing meshes a while back, the thought was the stronger the better. So they made very strong meshes. But then it ended up becoming like plastic, basically. You put it in, it just became cement. And it could erode into tissues because it was so strongly made. And then they realized that actually stronger isn't better. You have to make it more flexible and more lightweight. You start hearing words like lightweight meshes. Give it enough holes so tissues can grow in between. So stronger is not really better. It's more about the technology in it. Some of it even dissolves, and some of it stays permanent and incorporates into your tissue. Because at the end of the day, you want it to be part of your tissue and not separate from your tissue. And initially, it was made so strong that your tissue basically rejected it. But now you kind of make it nicely lightweight. Some of it dissolves over time, so your tissue incorporates and it actually becomes part of your tissue. So it's rare to see mesh erosion with the mesh technology these days. And then you have pain. Same issue with pain. It'll hurt, but the pain should get better, not worse. Epigastric hernias, those are the hernias that are between the belly button and the chest. So this space, this is the epigastric area. You can have hernias there too. And usually, you can have 2 or 3, even though maybe you come in just with 1. When you go in, you realize, oh my God, there's a smaller one there, there's a smaller one there that you didn't know because you don't see the bulge yet. It's more in men than in women. But the bulge is basically between the belly button and the xiphoid process. So this is the epigastric area, and there's a bulge. That's an epigastric hernia. But it's repaired basically the same way because it's a defect. It's a hole in the abdominal wall. It's repaired basically the same way like a belly button hernia. The surgeries are usually, again, about 1 hour. You can use the same technique again. You can make an open incision, but you see that will be a big incision. Now, yeah, if it's a very small defect, I can make a very small hole and just fix it that way, a small incision and fix it. But if I have to make a big incision, then I'd rather go small incisions to avoid a big cut in the middle. Because it's still 3 small ones on the side, no matter how big that hole is. So it's the same picture because it's the same kind of defect. Once you go in, you see the hole, you close it, and then you lay the mesh for reinforcement. All right? It's still outpatient surgery. You tend to realize that with hernias, they're basically the same kind of things. No heavy lifting, same rules apply. Stool softener so you don't get constipated. Normal activity is good, walking, light activity. I normally tell people the first week, plan to have a very light week because nobody knows how much pain you'll be in. Hopefully not a lot. But plan to have a light week so you can do things at your own leisure. After a week, then you can start doing more serious things like work if your work doesn't require heavy lifting. But at least plan to have a week off for yourself to take the time to do what you need to do, but stay active. Most people don't need to be out of work for 4 to 6 weeks unless you're really doing heavy activity. If you're doing desk job or something that does not require a lot of heavy lifting, maybe a week is all you need and you're good to go. Same shower, no baths. And basically the same complications again because it's basically the same defect. I have in my, I almost forgot. So this is a piece of cheap mesh. The mesh is, but it's basically, I'm going to pass it around. So the thing to take home with is basically very lightweight, very pliable, but it's still solid. All right? You want the holes there so the tissue grows in between the holes. Now there are different kinds of meshes. So not every mesh is like this, but it's the same idea. It's a piece of fabric like this. Some of it will dissolve, some of it will stay. But it incorporates into your tissue, and then if you go back like a year later, you realize that it's part of the tissue.
Thank you.
And I think, hold on. Let me see that picture. I'm going to go back a little bit. No, it doesn't show. Never mind. Now to incisional hernias. Incisional hernias are basically hernias when you've had surgery before. Whenever you've had surgery again, you have a risk of having a hernia. Especially if you did a lot of coughing after the surgery. Let's say there was a wound infection, so the healing wasn't good. If you're a smoker, the healing is not that good. If it was a major operation, usually there's some kind of complication. You end up at the end with a hernia, because there was too much tension. Overweight. So everything, you got to remember, once you've cut through, the tissues are not the same. The tissues are weaker. Malnutrition, if the person was sick for a long time in the hospital and had big abdominal operation, most of these people end up with hernias at the end. The healing was not as good. The stitches came loose. And they go home, and after a while you realize you see a bulge. There was a wound infection, so it didn't heal well, so now you have a hole there. You have a weakness. It's called an incisional hernia from prior surgery. So normally you see a scar. That's the scar from the surgery before. And when you look inside, you could have one hole. And sometimes when you look, you have smaller holes. You see, this is a smaller hole from a stitch. You don't see it just looking, but when you look inside, you see there's a hole there already. It just hasn't shown up yet. So what you see sometimes is this Swiss, we call it Swiss cheese. Many holes along the incision. You may see 3, 4, 5 holes, just small holes, just ready to get bigger and bigger with time before it becomes a bulge. That's classic incisional hernia. This, if you look really close, this was repaired with mesh before, and it looks like the mesh went to the side. You can kind of see the mesh, and the hernia opened up again. But that's how the mesh incorporates. You can barely see it because it grows into the tissues. It doesn't just stay separate. It becomes part of the tissue. You don't bother to peel it off. When I go back in to repair this hernia, that just causes pain trying to peel the old mesh off. You just use it, you just stitch it and leave it there. It's okay. The only reason I'd peel it off is, 1, if it's easy to come off, and 2, if the person was complaining of pain. Then you're like, all right, let me take it out. But if there are no complaints, if the issue is just the hernia, and that's nice and smooth, fine, and just leave it there. Because you cause more harm trying to take it off. So the repair is based on how big the hernia is, to be honest. Some incisional hernias are small, you can take care of it in 1 hour. Sometimes you can be in there for 2, 3 hours. If you have one of those long hernias with many little holes, then it takes longer. So it's all based on size. Sometimes you have to free up scar tissue because you have bowel that's stuck in it. So all of that takes time. Bottom line is you want to take your time and do a good job. You don't want to cause a bowel injury. You don't want to cause bleeding. So at the end of the day, you sleep. Yeah, you don't want to take forever because you don't want to be under anesthesia forever. But the goal is not to hurry up and injure something. The goal is to have a nice, good repair at the end with no injuries. Most of the incisional hernias are better done with the robot. Because if you have to do it open, you're going to end up with a big cut. To go in again, and then you're going to have to lay mesh. It becomes a whole big, and then you've got to move the bowels all over the place. So the recovery is way more difficult. Because you have a bigger incision, you've moved bowel, you've been exposed for a while. So the recovery is a little bit more difficult than if you do it with small incisions. Because if you do it with small incisions, it's still 3 or 4 small incisions on the flank, and you can do a lot of work inside, closing all these holes without moving a lot of things with a big incision. So that's definitely one of the advantages of doing this with a robot when you have a big incisional hernia. And we're always, if you're going to do incisional hernia, that's that big, if you don't use mesh, it's going to come back. It's going to definitely come back. But it's the same 3 picture you're tired of seeing basically by now, but it doesn't matter. The hole is in the middle. You got 3. You go in. There's a hole here. There's a defect here. You close it up, stitch it all from the inside, all with just the 3 small incisions. Once it's nice and closed, to avoid it from coming back, you lay your mesh for reinforcement. But the mesh is nice and deep, it's on the inside. Infection is really not a problem because you wrap it up. It's not, and you pass it through one of these trocar sites into the belly. And then you can unravel it, and then you stitch it nicely to the abdominal wall so it's nice and flat. So it really helps when you use the robot because you can do a lot on the inside with just 3 small incisions. And you can lay the mesh really nice and flat because you have full control of it. And then you can stitch it to the abdominal wall really nice after you close your hole. So it's a good repair. There is some pain afterwards, but again, the pain is going to be where the hernia was repaired. But it gets better. It gets better. So this could be outpatient or inpatient surgery based on the size. Yeah, the goal is to get you to go home, but we're not going to kick you home if you're in pain. It makes no sense. Some people spend the night, maybe sometimes even 2 nights. It all depends on how much pain you're in, quite frankly, and how you feel. But when you're ready to go home, we send you home with the same plan. Stool softener, pain medicine. Activity is good, just light activity. Same restrictions. If it's a bigger hernia, it's more towards 6 weeks than 4 weeks. So there's a little bit of play based on the size of the hernia. If you have a small belly button hernia, sometimes it's just 3-4 weeks. It's a small hernia. If you come in with a big hernia, you need 6 weeks at least, just because it's a bigger size. So these things cannot change based on how the situation is. And it's the same kind of complications. But the mesh definitely prevents the recurrence, and you just have to be careful not to injure bowel. Mesh infection, again, is very low, especially when you do it with the robot, because it's a small incision, you shove the mesh in. No risk of infection. And then the pain that we can manage, and the pain gets better with time. This is not a hernia, but I put this in because I see this a lot. It's called diastasis recti. It happens a lot in people who are slightly overweight, or women who've been pregnant or just gave birth. You try to wake up and you see this big ridge. You think it's a bulge. It starts from here and goes all the way down, maybe past the belly button, even all the way down. You're like, oh boy, I have a big hernia. It's not a hernia because you don't have a hole in the abdominal wall. This is an example of one. Did I turn the lights on? What happened? Oh, sorry. Just keep going, I guess. It's not a hernia. What's happened is, because you've gained weight, the muscles have shifted to the side. So you got a weak middle. So when you stand, muscle, weak in the middle, it bulges out. But if you look inside, you don't see a hole like this. It's plain. It's called diastasis recti because it's just a weakness. And every now and then I see someone come because they think they have a hernia, or a primary care physician sends them because they think they have a hernia, but it's actually when you don't feel a hole. There's no danger in it because there's no hole. There's no risk of incarceration. There's no risk of strangulation. It doesn't kind of get bigger. It just kind of stays there. And if you really want to get rid of it, it becomes a plastic surgery kind of procedure. But it's not a hernia. These are just my numbers. Because when I do the hernia, I basically send in my data. And the key note here, or the things to look at, is this is infection rate. This is basically for inguinal hernias. It's very low overall, 0.3. Luckily, so far, I'm 0 on inguinal hernia infections. They just don't happen, quite frankly. 0.3 nationally is pretty small. Very few people ever spend the night in the hospital. It's not even up to 1% overall. So if you just look at numbers, it's less than 1% for inguinal hernias. OR time, I would say between 60 minutes. Mine is kind of 75 minutes. I like to say I'd like to take my time, not to rush, But yeah. And for the ventral hernias, same thing. If you look at infection, in terms of mesh and things like that, especially when you use the robot, this is all robot stuff. Basically 0. Those 3 wounds do not get infected. They may get a little red and bruised, but they're so small, they'll heal. The mesh is put in deep, it hardly ever gets infected. The only way you can end up with an infection is if you kind of injure bowel, if you think about it. Unless you take the mesh and you decide to kick it around and then put it in the patient. Then that's a different story. But usually you pull the mesh out, it's still sterile, you put it in. No chance of infection. Length of stay in the hospital, honestly, the most is 1 day, maybe 2 days. I've had people spend 2 days because it was just a big hernia. And that's basically it on hernias.